Hi friends, welcome to Plexus Ortho. My name is Dr. Kanan Kumar. I am an orthopedic consultant at Plexus Ortho. Today we are going to discuss about MCQ number 206 that we put up a few days back in the Telegram channel. So the question is as follows. A 70-year-old female presents with a 15 days old fracture. So it's not a fresh fracture. Old displaced neck of femur fracture. What is the treatment of choice? So the age of the patient is high, that is more than 65 or more than 60 years old. So therefore, ideally in this age group we do not fix the fractures, because as we all know it's an intracapsular fracture and the chance of union becomes lesser with growing age, with increasing age, and therefore we have to prefer some kind of replacement. So what is the replacement that is usually done? It could be an hemi replacement with an Austin Morse prosthesis or a total hip replacement. What is the difference between a hemi replacement and a total replacement? Hemi replacement is only the head is replaced, whereas in total hip replacement both the head and the acetabulum is replaced. Currently, I think the right answer for NEET PG would be hemi replacement with an Austin Morse prosthesis. However, in the orthopedic literature it is changing and there's a lot of evidence towards total hip replacement. So, but currently I think the right answer most likely, or the better answer is a hemi replacement with an Austin Morse prosthesis. What are other options available? You can fix it with cancellous screws. As I said, do not fix it with cancellous screws. Cancellous screws is for somebody who's less than 65 years. Total hip replacement could be an answer, but the ideal answer is an hemi replacement with Austin Morse prosthesis. Derotation boat is a conservative or a salvage treatment for intertrochanteric fractures, and it's not a treatment of choice for neck fractures, especially displaced neck fractures. So let us classify the proximal femur fractures. How do we classify it? We classify it into femoral head fractures, or we classify next is called the intracapsular fractures. So this is the intertrochanteric region. This is the greater trochanter, this is the lesser trochanter, and this is the intertrochanteric region. Anything proximal to that is inside the capsule. The capsule is attached right here, so it is proximal to the intertrochanteric line, and anything proximal to that is called as intracapsular fractures. These fractures have a poor blood supply. They have poor blood supply and they are bathed in the synovial fluid, just like the scaphoid fracture. Proximal femur or the head fracture, head and neck fracture is bathed in the synovium, and therefore they have poor potential for healing and they have a higher chance of non-union. So the IT fracture is the fracture that happens between the intertrochanteric region, between the greater trochanter and the lesser trochanter, and this is called the IT fracture or extracapsular fractures. In extracapsular fractures, the chance of union is much higher. They rather go into malunion. They do not unite in the right position because they have good blood supply. They don't have the synovium bathed around them, and therefore they have a good result of malunion. How do you differentiate between neck of femur fracture and intertrochanteric fracture? Neck of femur fractures are lesser shortening. They are external rotated less because they are held by the capsule. Whereas the intertrochanteric fracture, there is higher shortening, there is a tenderness at the greater trochanter region, you can feel it on the lateral side, and there is a higher external rotation in case of intertrochanteric fractures. So let us say this is the intertrochanteric fracture and this is the neck of femur fracture. The differences are as follows. Intertrochanteric fracture, increased external rotation, whereas in neck of femur there is lesser amount of external rotation. There is external rotation, but there is lesser amount of external rotation. In IT fracture there is increased shortening, and here in neck of femur there is shortening, but much lesser extent shortening is present. And these are the two main basic differences between the IT fracture and neck of femur fracture. This has been asked very often in your exams, so you must know this very clearly. Now, how do we classify these neck of femur fractures? Neck of femur fractures are classified based on two classifications. One is the Gardner's classification, the second one is Powell's classification. There are many other classification systems, but these two are the commonly used classification systems. Gardner stage 1 is an undisplaced incomplete fracture. In Gardner stage 2, it's a complete but undisplaced fracture. So therefore, what you should remember is undisplaced fracture is Gardner 1 and 2. undisplaced in garden 1 and 2, whereas in garden 3 and 4 it is displaced fracture, partially displaced in garden 3 and completely displaced in garden 4. So garden 1 and 2 is undisplaced fracture, whereas garden 3 and 4 are displaced fracture. So whenever they mention anything about displacement in your question, go ahead straight to garden 3 and 4, whereas when they say undisplaced fracture, go to garden 1 and 2, right? So what is the next classification system? This is called as the Powell's classification system, based on the Powell's, P-A-U-W-E-L, Powell's classification system, where it is based on the angle with the horizontal. So how much is the angle here? In type 1 it is about 30 degrees, in type 2 is 50 degrees, and in type 3 70 degrees. The more horizontal the angle, the higher chance of union, because there is better compression between the fragments and there is union, whereas if the angle becomes more and more oblique, there is shearing rather than compression, and therefore in 70 degrees or in type 3 fractures there is a decreased chance of union. So what do we see? There is an increasing chance of non-union from a smaller angle to a larger angle. So when the angle becomes more and more, there is an increasing chance of non-union. Remember this, right? Now let's go to a little bit about the blood supply. These questions are asked often in your exam, so you must understand it. There are 3 sources of blood supply. First one is the foveal artery, which originates from the obturator artery and enters through the ligamentum teres. Through the ligamentum teres, it enters the head and gives a supply to the part of the head. The second artery that arises from the profunda femoris vessel, from the profunda femoris artery, is the lateral femoral circumflex artery. Lateral femoral circumflex artery. The third vessel that arises is called as the medial circumflex artery, that arises again from the profunda femoris artery. It's called the medial femoral circumflex artery. All studies have shown in adults the medial circumflex femoral artery is the main contributor or main blood supply to the femoral head. The main blood supply is the medial femoral circumflex artery. At the level of the capsule, once they enter the capsule, they form what is called a subsynovial intracapsular ring. So therefore, if there is a fracture right here, it causes decreased blood supply to the head and there is a higher chance of non-union, whereas a fracture at the level of the intertrochanteric region, it has great amount of blood supply and therefore it goes into malunion rather than non-union. Remember this very clearly, right? So a fracture neck of femur, lesser external rotation, lesser shortening, higher chance of non-union because it is intracapsular, whereas a intertrochanteric fracture, it is extracapsular, it's outside the capsule, and therefore higher chance of union, higher external rotation, higher shortening, and goes into malunion rather than non-union. So let's go to the algorithm of how do we manage this fracture neck of femur fractures. So let us see, the first criteria is the age. If the age of the patient is less than 65 or if the age of the patient is more than 65, the treatment changes based on the age. If the age is less than 65 and it is an undisplaced fracture, try cancellous screws. So if you have an undisplaced fracture here, try cancellous screw fixation or fix it with some mechanism. So fixing the fracture is a priority in a less than 65-year-old individual in an undisplaced fracture. If it's a displaced fracture, still try fixing it, fixing the fracture with possibly an osteotomy called a Mack-Murray osteotomy. Mack-Murray osteotomy, or you can even use a vascular muscle pedicle graft. You can use a vascular muscle pedicle graft, right? So therefore, if the patient is less than 65, if it is an undisplaced fracture, please use a cancellous screw fixation. If it is a displaced fracture, fix it either with a Mack-Murray osteotomy or a vascular muscle pedicle. If the patient is more than 65 and if the fracture is undisplaced, you can think about fixing this, doing an ORIF, fixing it. However, if it is a displaced fracture with a late presentation, the only option is either an AMP, that is an Austin Moore prosthesis, hemi replacement, or a total hip replacement. Total hip replacement is increasingly becoming the vogue, and it is a choice of treatment in orthopedic literature. But I think in NEET PG, even now your answer, the better answer is an Austin Moore process. So to go through the algorithm again, age is based on the age. Less than 65, undisplaced, please always fix it. Displaced, still fix it with McMurray's osteotomy or some kind of muscle pedicle graft. Whereas if it is more than 65, undisplaced, you can try open reduction internal fixation, or if you think you can still, even in undisplaced fractures, an AMP, Austin Moore process or a THR can be done. So basically you can divide the age into less than 65 and more than 65. Less than 65, try and fix the fractures. More than 65, you try and replace the head with an Austin Moore process or a total hip replacement. So this is how a cancellous screw is used. Usually 3 cancellous screws are used, 1, 2 and 3. They're used, 3 screws are used, and these screws must engage the femoral head, and this is done in less than 65-year-old patients who are having undisplaced fracture. Even displaced fracture, you can try and reduce them and fix it in case of less than 65-year-old patients. Then this is the Austin Moore prosthesis. Austin Moore prosthesis is a monoblock single piece of metal which is used as a hemi replacement or for the neck of femur fractures in older than 65 patients with who have an undisplaced fracture. Nowadays, THR or total hip replacement is more in vogue. That is, you replace the acetabular component as well, and you also replace the femoral component. The acetabular component is replaced with a polyethylene material, whereas the femoral component is usually replaced with cobalt chromium material, and you can either insert it with cement or without cement So let's just have a brief recap of this question that we discussed. One is, the patient was a 70-year-old female who presented with a displaced fracture of more than 15 days duration. This kind of fracture, it is better to be replaced. Usually an Austin Moore prosthesis hemi replacement is sufficient. What is the Garden classification? Garden classification 1 and 2 is undisplaced fracture. 3 and 4 is a displaced fracture. So 1 and 2 you can try fixing with screws or some other method of fixation, whereas 3 and 4 you can try using a replacement methods. Then Powell's technique, Powell's classification, where the increasing angle, that is increasing in the obliquity of the angle, converts the compressive forces into shearing forces, and therefore there is a lesser chance of union. So Powell's increasing angle indicates a higher chance of non-union. Then we have the blood supply. There are 3 sources of blood supply in an adult femoral head: lateral femoral circumflex artery, medial femoral circumflex artery, and foveal artery. The major blood supply is the medial circumflex femoral artery. And the algorithm we have seen: less than 65 years, undisplaced or displaced, try and fix it. More than 65 years, undisplaced, you can try fixing it. Displaced, always replace it. So these are the main points about fractured neck of femur that you would get in your exam. I hope you have understood this question well. My name is Dr. Kanan Kumar, and this is Plexus Ortho. Thank you very much for hearing me out.